صباح الخير. دكتور حسنى، صباح الخير على حضرتك. دكتور وليد، دكتور جابر زيادة، دكتور خالد طلب، دكتورة هالة. Allow me today to present my role of FDG, PET-CT, and triphasic computed tomography in detecting post-thermal ablation as early treatment response of malignant hepatic focal lesions. This work was done under supervision of great Dr. Hosna, Dr. Hoda Fathi, Dr. Jihan Al-Hanawi, and Dr. Shadi Sabai from the NCI. To begin with, liver malignancy constitutes mainly of HCC and secondary tumors. HCC ranks as the 6th most diagnosed cancer worldwide, 3rd cause of cancer-related death, and nationally comes first in incidence and mortality, while its secondary tumors are far more common, with 18 to 40 times more common, especially from colorectal carcinoma and pancreatic and breast cancers. When it comes to methods of diagnosis of malignant liver tumors, we have clinical laboratory diagnosis, histopathological confirmation, and imaging modalities. Imaging modalities constitutes of morphological imaging and functional imaging. Morphological imaging, we have ultrasound, contrast-enhanced ultrasound, triphasic CT, and MRI. Then we come to the functional imaging modalities by ethylene FDG PET-CT. As we all know, CT and MRI assess changes in tumor size, perfusion, enhancement, density, or diffusion, which does not reflect the actual pathological tumor responses, especially at early stages. However, by functional imaging, we assess the metabolic or cellular changes which precede the changes in tumor size or tissue parameters, and hence we can accurately, or it can provide accurate assessment in the success of local ablative treatment, and can help identify residual or local tumor early or immediately after intervention before inflammatory changes. Treatment modalities of hepatic neoplasms include curative approaches and non-curative approaches. Curative approaches as liver resection, liver transplantation, radiofrequency or microwave ablation. Non-curative tumor therapies, we have chemoembolization, radioembolization, and systemic chemotherapy by sorafenib. Regarding the assessment of treatment response, we have challenges, especially in the formation of inflammation. In CT and MRI imaging, hyperemia is responsible for increased contrast enhancement immediately after RFA, while tissue regeneration causes a persistent increased contrast enhancement for a longer period. Both phenomena prohibit the identification of residual tumor or recurrence with these imaging modalities after the RFA. So the aim of our work was to compare between PET-CT and CT in assessing the treatment response, as well as predicting the local tumor progression following RFA, evaluate the ability of PET-CT in detecting immediate therapy response following the RFA, assess the accuracy of baseline FDG PET-CT in characterizing malignant liver lesions and detecting extrahepatic mets initially, and lastly, correlate baseline tumor size and metabolic parameters in predicting local tumor recurrence and overall survival. Our methodology, our study was prospective study conducted in the NCI, included 43 patients with mean age of 60 years old. All patients had hepatic malignancy, they underwent RFA, and they did both FDG PET-CT and triphasic CT at 4 time zones. Baseline pre-ablation scan, immediate PET-CT following the RFA, at 4 to 6 weeks after ablation, and then at follow-up scans done with median of 6 to 18 month period of time. Delayed imaging performed when we encountered isometabolic lesions. Patients underwent delayed imaging 2 hours post-injection. Semi-quantitative analysis was done by the SUV max. Also metabolic parameters were recorded. And the PET-CT interpretation criteria was as follows. We had 3 patterns. Pattern number 1, when we encounter no FDG uptake between the ablation zone and liver parenchyma, and this scan was interpreted as negative scan. Pattern 2 is when we encounter DRIM-like FDG uptake with or without interruption, and this was rendered as equivocal pattern. And a third pattern is when we encounter nodular FDG uptake, whether small or large, and this was interpreted as positive scan. When it comes to the results, general characteristics of the study's participants, mean age was 60 years old. There were male predominance, 60% of the sample was males. HCC was the dominant pathology, with 80% of the patients had HCC, and most of the patients, 95% of the patients, had single segment involvement. Out of the 43 studied patients, 26 patients had isometabolic lesions, and only 16 of those patients underwent delayed images. 4 of those patients showed positive images at the delayed scans, while 12 patients only had the negative results. Diagnostic accuracy for immediate PET-CT in the detection of residual disease. At the same day, we observed that the PET-CT had an overall accuracy of 95% in detection in the immediate detection of residual tumoral tissue at the same day after RF ablation. At 4 to 6 weeks interval, PET-CT had an outstanding overall accuracy of 100%. Compared to the Triphasic CT, which also had an elevated accuracy, actually also in detecting residual tumor tissue at 4 to 6 weeks. At the median of 12-month follow-up, PET-CT and Triphasic CT both had the same overall accuracy with 95%. When it comes to the PET-CT versus a conventional CT in detection of extrahepatic metastasis before ablation, PET-CT outstanded the conventional CT with a percentage of 97% compared to the conventional CT with an overall accuracy of 79%. We found that baseline SUV max as well as TLG and MTV actually saw positive predictive value in predicting local tumor residual and or recurrence. However, when it comes to overall survival, none of the metabolic parameters showed any correlation to the overall survival, and we only found that the baseline or initial size showed a negative prognostic value when it comes to the overall survival. Case presentations. We have case number 1. This patient had active hepatic focal lesion at the left lobe. Oh, sorry. Immediately after the RF, these are the immediate images. The patient showed successful complete ablation, and all through, also after at the 4 to 6 weeks images and at the 18-month, the patient showed complete ablation through all his follow-ups, and this actually is the normal or the expected outcome of patients with RFA. Case number 2, this patient had active hepatic dome, hepatic focal lesion. Immediate PET-CT images showed a rim of activity at the ablation zone. At 4 to 6 weeks PET-CT images, we found that this rim of activity actually showed a progressive course, and this patient was rendered as having a positive malignant residual tumoral tissue. Case number 3. This patient had also active hepatic focal lesion. Immediately after RF, the patient showed complete ablation. At 12 months, the patient still had complete ablation. It wasn't until 2 years, at 24 months, the patient showed actually local tumoral recurrence with this active focal uptake noticed here. Case number 4. This patient, initially, we could not actually see or observe the hepatic focal lesion. It was isometabolic. We did delayed PET-CT images, and we observed increased focal FDG activity. Patient underwent RFA, and it was, from our perspective, a successful ablation. However, this patient, to our surprise, developed activity at 46 weeks. And so it was interpreted as false negative, that these images were not actually, this patient was not actually negative, as evident by the 46 weeks PET-CT images. And at the follow-up of this patient at 12 months, patient actually showed progressive disease, as evident even by intrahepatic and extrahepatic mets. And this patient actually developed metastatic lymph nodes, supra and infradiaphragmatic metastasis, nodal lesions. Case number 5. This patient had segment 6 active hepatic focal lesions. She underwent RFA, but not at 24 hours. She did the PET-CT images at 48 hours, and we observed a rim of activity all over the ablation zone, with actually focal nodular uptake also. And we could not really decide whether this an inflammation or residual viable tumor tissue, or actually both pathologies. It wasn't until the images of 4 to 6 weeks when we noticed that there is a progression of the activity, and this patient was rendered as having a positive for residual residual active viable tumor tissue. Regarding the limitations, actually many lesions, and by many I mean many lesions, appeared as isometabolic focal lesions, with only 25% of the patients had positive delayed images. Limited follow-up time, the 6 to 18 month median follow-up, may be insufficient to observe all potential long-term effects of the treatments, particularly for late recurrences. Limited data on other ablation techniques like microwave ablation or cryoablation, as our study focuses primarily on RFA. We definitely encountered difficulties in persuading patients to undergo immediate PET-CT following RFA. When it comes to the conclusions, PET-CT is provided improved specificity and accuracy compared to triphasic CT in detecting residual or recurrence after ablation, especially at earlier time settings. Delayed PET-CT imaging might enhance the detection rate for isometabolic lesions, as detected in 25% of the patients in our study. Immediate PET-CT after RFA ablation of malignant hepatic focal lesions proved to have a significant value in early detection of positive residual tumoral activity. And finally, only the tumor size, or the baseline tumor size, showed significance to the overall survival, unlike the metabolic parameters. Recommendations, we need to investigate the optimal timing and application of delayed PET-CT imaging for isometabolic lesions in cancer liver. We recommend performing immediate PET-CT within 24 hours after RFA, as it offers a better window for detection of early residual tumor before inflammation becomes a significant confounding factor. Conduct longer follow-up studies, multi-center studies of patients to validate the findings and improve the outcome of therapy, and finally explore the potential benefits of PET-CT in the context of other ablation techniques like microwave ablation and cryoablation. And thank you.